right up on the platform and snapped one well-prepared gari and soup. And that he has not taken that stuff in a Bible since they are alive, whether that stuff is spiritual or physical. But the truth is, we have enough of that in a Bible. Make sure you see me, let me take you out. Yes. I think I can take 10 people. Yes. When it comes to all those very Bible is number one. Thank you very much. And so today, we will be fast with everything we want to do. And according to the style of my organization, we like to ignite passion in persons when it comes to research, when it comes to skills, when it comes to doing things well. The whole world is waiting for someone who can deliver. Not too much of grammar, too much of theory. In my organization, we talk about tertiary institutions with a theory. Not much of what we can do with our hands. And so, this aspect of drug administration, we would like to hit the nail so that it gets right into the wood, even within the short time that we have. And so I'm going to start by showing us this. I have a reason for it. This is cefuroxime acetate, 125 milligram per 5 mil. Agreement we have. The other 60% has come by 9. And so the fellow wants to mix the injection for me, that block injection is whatever. I now mix this for that. And so I want to introduce something to us even right now, so we can practice it. And I want to pass it on to us because I think it's quite vital. This form says cleanse medication pack. If you are going to have to give injections in your facility, try and do something like this for each person. Let their name be there. Here I have name, home address, sex, age, all those demographics, next of kin, the person's personal physician. I want to ask you, you have come to my pharmacy. I'm asking you, who is your personal physician? I don't have one. I want you to go to the hospital. There are quite a number of such people. Fine, you can put name. And if it says doctor, doctor, whatever, put it there. You have this number, put the number there. Are you seeing a new face to pharmacy practice, even at the community? Am I saying something? Yeah. Good. So let us try and develop something. It doesn't have to be like this, but it can be similar to it. And so the drug the person is taking, we put it there in that column there. Then the prescription, is it once, twice daily or something? We put it there. Who prescribed it? We put it there. And then I'm going to be the one administering it. I want to be responsible for this administration. And I have given a number of injections, sincerely, all the glory to God. I've not had a single complication. The constant rate, high, a name will enter there, parent, legal guardian, self, caregiver of the name of whether it is that self, the name will appear again. Do hereby consent to pharmaceutical stroke first aid care, a care provision determined by the clinical pharmacist. I'm a clinical pharmacist, okay? To be necessary for the welfare of good child, ward, relative, self, while the said bearer is under the care of my name applies again and person signs. So I'm not giving you injection because I don't have to give me put a, I'm not doing that. So I'm asking us to make it very formal, very official. Put all these things into record. And so if you're coming for the second dose, I'm going to ask my staff to bring this and say, are you Mr. Dauda? Okay. All right, then let me be sure everything has to be what? Documented. Let me know about that matter. And I know that in our present days, nurses they don't give injection anyhow. Nobody's writing down what you've done. You do it correctly. Let the person see that actually have it and confirm that the injection is for him and all of that. It makes a lot of sense. And it gives the confidence that this person is getting it. It's not like that. You want to go get it. It's not up to us. I get very pharmacy, but it's not sure. Now, if you say again that we're not going to give drugs that are prescribed, you don't listen to people that have arthritis or maybe simple stuff like that. that by now, they should allow pharmacists to have if you don't do those things, then there will be no space in the hospitals for people to do pharmacies. We have seen how you do your injections. We have seen how you practice or whatever. Now you are free to, and I see that coming to pass soon in Jesus' name. Amen. That laughter is like never. It will. If I have my colleagues in clinical pharmacy, University of York here, I've seen one, maybe he left, but I saw him towards the door. About 6-7 years ago, when I started HOD, okay, put a kind of a laboratory manual to teach my students how to handle needle, how to do this, how to do that, how to see when drips are. Say no, don't do. But about 2 years ago, NUC came and they were so happy to see the practical manual. They were happy to see my students reporting this and that, graded. They went away with the manual, the lab manual. And I'm so happy today that I'm before my colleagues talking about the same parenteral drug administration. Not only the parenteral, but the pharmacokinetic what? Implication. All the people doing injection up and down, they don't have any respect for the pharmacokinetic implication. Just to took. But you are going to tell them, no, now that you are choosing this route, IM, or you want to give IV. The fact is, bioavailability is this, is that, is this, is that. They are going to respect us. But if you keep saying bioavailability is this, volume of distribution is that, but you cannot even hold a needle and syringe. You got to look at it. Sincerely, you must be all round. Even if you are not going to handle it, but this is an hospital setting. But you should know how to do it. I think you should try getting a car with a driver and you don't know how to drive. One day, you see this. We have ascertained that the injection we have with us is for this person. So the first thing to do is to introduce ourselves to that person. Good afternoon, ma'am. Good afternoon. My name is Dr. Sunday Ufusaya. I'll be the one handling your injection today. Do the introduction. Let us start by what? Oh yeah, madam, come. Madam, come. Come and take your injection. That's good. Is it not good? I'm fine. When the fellow comes for that injection, I have my tray here. I have my tray. If you're going to do injection in your premises, why don't you get something like this? It's not costly. So my staff, when they want to give injection, they come and see they're serving me a meal. Again, you say nothing. When you bring the card, the body card, it was supposed to be IV. But this fellow has used lidocaine. And furthermore, use a scavenge put for me to. So we have to discard the scavenge and put a. Even though the record we have is that this injection is for IV. The fellow probably saw the IV. I don't know what. So the truth is, you as the pharmacist, the head of that institution or that community pharmacy, you will need to, be sure. So you don't make mistake and you start doing the blame game. And it was my. Can you even say it was my staff? Don't even say it. Don't even let anybody hear it. Because it is you. Say, I hold on. Because if that happens, there's a kind of discomfort to suffer for close to 1 or 2 months on that. Okay, so we need to be familiar with, even though we just wake up and there are 2 of these. This is water for injection. This is okay. I want to do IV. This I'm going to use. And then look at. So if I break this and draw 8 mils of water and prick into this and put in there and draw it out, I cover my needle and syringe again. When it's time to shake this, most people put their hand on this. You don't have to put your hand there. I have this like this, and then see my finger here. I'm holding the base of that needle. I've removed it. Can you try and do that? Be careful that you don't prick yourself. But it does happen. Look at what I've just done. I've just engaged and I'm still holding this in a way that it doesn't pour. So I'm holding it upright, and I just brought this and put here. I just do what I'm doing if you have your needle. And there's injection water in your bag. So you can bring out your injection water. Is it that? And if you're not going to snap open that way, then you need to swipe the body of your injection water. Because they give us injection water. It's in the box where dogs can set food. Ladies and gentlemen, please let me not be too fast. Do your CPAN, 2 meals. Thank you very much. Now, you are likely to have some air bubble inside the syringe. There is a way, look at, I'm pressing the longer bumble on my, okay? And now bend it a little, like this, so that the air inside will be close to the base of the needle. Because, sincerely, if you don't learn this skill, you are going to push out all your, about 1.5 mil out. You now have 1.5. My client was going to do alpha beta for me, and I was going to inject the MD of BIOSCIRD, and we had only 1 mil. I said, where is the other 1 mil? He says, I can spot. Bro, where? No. I won't give 1 mil. It's a close. Okay. So now I'll just bend like this to the bubble without using. I lost something, but don't see any difference as such from that 2 mil now. So this is ready. So once this is ready, we allow our patient or our client, okay, to take the right position. In fact, we assure the person that my patient doesn't pain me. There's a psychological stuff when you are told him, when I give injection, people don't feel it. Hold us on a palm here. Okay? Now, I want to advise us that we don't use the median vein. There's always one vein at the middle here. Over the years, I found out that when I engage that vein, somehow it wants to swell, a kind of phlebitis. But if you use the basal here or the cephalic here, they don't give problems at all. Then be sure that it is vein you are seeing, not tendon. Go around and make my audience to do their hand like this, so you can see veins. This is vein. This is if you can see vein. I know for ladies, fatty stuff can you are not likely to find there. Vein are found on the what? Yes. So I will kind of come around vein. So there's a skill, there's a way to time. So when you now want that everything opens up. The angle that the vein must be about 15-25 degrees. And we shouldn't go too deep. If you go too deep, you can get to the vein and walk out of the rear. But you can't talk. So that when you walk, walk out. You don't pop out. Get out of this. I don't want it to pop out. When that happens, just when I'm not like that. When you want to pop out, you don't pop out. Because sometimes you want to keep injection pressure. See my hand. You are putting it's already happening for you. Because what they start does it, and he or she not get it. I'll just come around. It's gastrointestinal. Something wants to make them throw up, and the fellow wants to control it. But you know we can't control those kind of before you know it, wah, on your body and everywhere. So if the person is talking with you, still ask, are you fine? Are you okay? Don't just be busy trying to push everything in. And of course, I know we know that IV injection is what? Slowly. Don't push it like IM. It's slowly. So do it slowly. Engage the person. Sometimes you don't need to. If he says, I feel like vomiting, all it calls for is for you to stop. Allow the person to do what? To calm down. And if you're going to further push, let it be much slower. Are we together? We are going to become professors in this area very soon. I guess what happened before now is a kind of a euphoria, a kind of you are going to kill somebody. Why are you going to? You are not going to kill anybody. You don't go to pharmacy school because you want to kill, and God will not allow you to kill, and you are not going to kill. Got and deposited him at a teaching hospital. Of course, we went to police station, collected. Nigerians can make this complicated. We are trying to help someone. Police is doing. Everybody's doing. May God help us. And so now, it's okay for us to still look at this. metronidazole. I'm sure we have this, we know it, and it's very useful. Metro is a household whatever. Sometimes tablet will not suffice. You have to use this, and so we must have to disengage this in a way that the needle will not fall. There's always a slit somewhere here. But this nylon is friendly. There's some nylon that are very strong. You will pull and draw and draw and draw. It's not going to respond. But there's always a slit here that you can slit it and bring out this. And most of the time, when you bring it out, the needle wants to fall down. For me, I'm already said, can you see it? It's falling. I don't want to pick anything from the floor. So are you seeing this here? So as soon as I remove this, the first I want to do is to lock, is to close this. That's the first thing to do. After removing from the sachet, is to close this. Most times we forget to close. I will now come and put this. Then when we are putting this, let it be just straight on. Don't bend. If you do, there might be leakages. And leakages will make that treatment very, in fact, you want to discard this and use another one. Put on one time. It will now run, and this time is running. I'm not going to have a drop on the floor. Why? Because the tip is higher than, this one is higher than, are you with me? There won't be any drop. Why don't you want drops? If it's just water that you are doing, and drops fall, before you know, ants will come and fill that place, and even climb your patient. Doctor, this ant are they're not very neat stuff. So as it is like this, if I keep like this, the next thing to do is to put my staff in. Okay, I can hang this now. If what? It will drop. But I'm going to make sure it doesn't. If that happens, what you need to do is just turn this one like this. Okay? You can press this in. Okay, let me remove it. And treat that. If that happens, if you do that, then you can see the rate at which flow rate or drop rate. In pharmacokinetics, we call it flow rate. Because we want to do some calculations on that flow. Okay? Fine, so let me put this one down. And I know I'm done with setting this up. A question? This is 23G scalp vein, or we call it children scalp vein. There's 21G for adults. Okay? Me, I like to use this one a lot, but if you are using for adults, some people's red blood cells can actually make this clot faster. Because the size of the red blood cell as adult is not the same size as in children. So this one easily gets blocked. Okay, so this is ready now. I just put it this way. Now, I want to prepare my patient for me to put this. Like we have said, we are going to use a place where there's no lashes, that the skin is okay, the vein is visible, and then the person can conveniently. Don't come and put here and the person is doing like this for 30 minutes or some or 1 hour. If you
want to drop, please. You are drawing your syringe, please. This is my syringe. I want to pull out something. I'm doing this. I'm using just one hand. Let me go back again. I want to drop. Put your syringe
this in a pharmacy. How are you doing? Oh, I'm fine. All right. Follow. We'll soon become #1 profession in Africa or in Nigeria. Like they say, pharmacists are #1 in Velo. Is it just like that? And I've come to find out pharmacists are very honest. We have high profile integrity. But the truth is that our contribution, especially at the primary healthcare center level, will help this nation to go up. Now is for us to tie the tourniquet and put it and apply our strapping. Are we together? Now sometimes you are not going to do this once. You want to do a repeated, then we are going to need to use a cannula. Only some people say, no, I don't want people to tell me, in a Bible, for instance, when you have a cannula, they will not let you go. Ayakwe means your problem will be what? Will be over. They will start sympathizing, whereas their sickness is more than your own. You are only treating a small infection. They have a end-stage renal disease or something. They are not telling you, okay? So you may not want people to see that. They were going to have to use this every day. But if you don't care, then it is okay to use a cannula. Then to carefully put it in place. You can miss it. So I love to use these two, yellow or blue. And so let me disengage it. Open here. I just open it. There's pink too for children. Yeah. So now I disengage this. Look at the wing. So before you put this into the person, you are going to have to slack this one a little. Don't let it fall out, just slack a little. So it's easy to. Now, you just hold like this. See, look at, I wish we had a. I'm just using my last to hold this one. I just say I'm holding it. Okay? I just remove this. I swap the place. I put the tourniquet in place, and I put the skin a little. Because if you don't put the skin a little, this thing can stay on the skin, and the skin is becoming rumbling and it's paining the person. But if you draw the skin a little like this, so that you can have a clean entry, the pain is less. And then once you do that, just try. Sincerely, I know we can't jab one another here. But the one we did with young pharmacists group, we had to pair people one by one. Yes, just get the pain. When I was in school, I wanted to do red blood cell, whatever. Somebody would jab you. Where would you find blood now? It's from that sacrifice. Okay, so look at this one here. Why I'm blocking this at the back is, if you don't and you do like this, it will push this one back. So once you put this, it goes into that skin, and then you're going to see blood there. Once you see a little blood, fine. Just put this one to lie on the person's skin, and then apply your strapping, the plaster. Then, having done that, you now come and pull this one out. As you are pulling this one out, put a pressure on up that way, so blood does not flow and start dripping on the floor. So once you do that, you remove this. Quickly, see you are holding this one. Because you say you want to put it here, I come and remove this, and come back and remove it, blood will flow. So just remove this one like this, you don't need any more. But this will have been in my own hand. I'll just put this one like this, remove this and drop, and then I'm not going to do that for this one far away. Before blood will start dripping. And so I now finally strap it. There's a way it is strapped. So it's easy to pull it out. You put the plaster directly like this. Like there's someone and then put this, put the first plaster, then put another plaster under here. Thank you, my guest. Yeah, so everything is covered. So the next one is coming. Okay. So this one is coming under here. Yeah. Okay, so I'm going to now press this one like this. Do you get it? That's the way it's always placed. The other one goes, you can show, let me show them. And to remove that, you just strip and then you bring it out. Important. We know how the second hand goes, tap, tap, tap. If this dropping, alright, when we get back home, we can try this out. Look at the way this thing is dropping. Is it faster than a second hand? Yes.
Yes.
It seems it's slower, a little slower. Fine. So I'm going to set it again to be exactly the way the second hand goes. It's still a little slower. A little faster. Yeah. So you can actually set it so you can have 60 drops in 1 minute. The volume of this one drop is 0.05 mil. If it is 0.05 mil and you have 60 of such in 1 minute, then we know how much of metronidazole has gone into that person's body. You will agree with me that our friends in other whatever, they don't want to sell that thing and say they are not looking at how much. All they want to do is 3 of this in a day. They get as well money and now because of the time, if we're to run in 3 days or 4 days, then we'll have, yeah. So now, when there's an emergency, most times we have what we call IV rush. IV rush, because you don't want hypovolemic shock. You don't want and then you want to load the body like achieve a concentration in blood that is up to the MIC. So that's the reason for such a, and so like I just said, if it's going like this, that's 60 drops per minute. You can make it 120 drops, it can be 180 drops, it will ta-ta-ta in one peg, ta-ta-ta, peg, ta-ta-ta, peg. But the truth is that we must make sure we don't over rush it as to pose a challenge to the cardiovascular, to the heart. Because everything that you are putting here, where is it going to? It's going to the heart. Also on OTC. If I stop your pharmacy with OTC, so that the Lord does not catch up with you. Your uncle that is taking one particular drug for BP and it seems he's not responding, and you know what the JVC 17, you know what it says, you know what the first line is, you know what the second line is, and maybe somebody is even prescribing something out of that whatever. It's your relation here. You may want to make a contribution. But the truth is, that fear, according to my brother, he says, if the fear. So the truth is, if you and I don't make the contributions we have been making in our community practices, and here and there, if you don't make it, I'm sure the hospitals will be overflooded. They will not cope. But if you have been contributing, I think the Minister for Health should even call a kind of an assess and see what contributions, not just that conflict of a doctor, pharmacist, nurses, what we gain from all of those things. That is. And the truth is, at that point, it now dawns on us that all the protocols of running a community pharmacy is not going to be there enough. It won't be there. For you to run a successful community pharmacy after retirement, you must have been doing some kind of local while you want sincerely. That's just the irony of it, okay? Not the important here. Do you have any question?
Probably it has been taught, but I did not really capture it. I want to find out if I just got to my house and I found out that my patient or my relation or someone has been sick, I got home, or my attention was called, and I got home and I discovered that my relation, maybe by whether a child or whoever, has been sick, who has been sick, suddenly became very critical, and I want to infuse, let me say, dextrose saline, for instance, or I see a nurse infusing dextrose saline, and the nurse want to fortify with something like 50% dextrose. I don't know if I was, or they are giving dextrose in water, and then now the condition of that patient, the nurse now pick a sachet of 50% dextrose, and also want to fortify that. Yes, I don't know how to calculate it or what, if the nurse is doing mistake. Myself being the drug expert, how will I maybe correct what the nurse. I don't know if you have experience with that.
That you and I should go and say something or say no, but we can't because we don't even know how to hold the needle in the first place. Sincerely. So back to my chairman's question. 5% dextrose water or still line. Okay? 500 mil. Then somebody is bringing, I guess he's going to use scissors to cut the small sachet of 50% dextrose water and start using 10 mil to push into. What is she doing? Because I don't even understand that kind of. If you want to use a higher strength, why don't you use 10%? Or is it afterthought that you didn't know that you needed? But what's missing for you to want to now bring it? My chairman, sir, if you see some nurses, they'll cook soup on top of your drip. You have to not turn black. They don't put everything inside there. Just what do you have there? What do you have? It's not as if there was a pre-planned treatment. It's just to be put in and just load it. They load it, the box. If I use that word, I want to box it. So maybe I don't know if it's to calculate. It is Bible and paper that we're going to use. If I teach pharmaceutical calculation also, 500 mil times 5% plus 50 times divided by total. But what are we actually to achieve with that? So my chairman, sir, I don't know what the nurse wants to do really. But this is our, we are drug experts. But look at what she's doing, and we are folding our hands, looking at the.
What situations you want to fortify?
Not to give 5.
You want to fortify.
Okay.
There are some clinical scenarios where you don't want to, because 5% dextrose in water, for instance, will give you 5 grams, total of 25 grams. And for some reason, maybe you want to give that patient a 45 gram load without increasing the volume that you're pushing. So the way to achieve that is to fortify. So what is important, and then sometimes you see some interesting prescriptions, like you can see 4.3% dextrose in half normal syrup. And the pharmacist who doesn't know will say, what is this? It does not exist. It's not true. You're supposed as a pharmacist to sit down there and calculate and tell them how many mils of what will be used to fortify. So there are certain clinical scenarios, you don't worry it out. But you must do a calculation. So if I want to give that patient a 45 gram load for whatever reason, and I have 25, I know I need to add 20. So how much of the 50% will I take? That is 50 gram in every 100 mils. So if I take 20 mils of the 50% and I add it to that 5%, I give the patient a 45 gram load. As long as that is not arbitrary, I don't want to give 10 gram, 10%. And 5% is too small. So you have to fortify. You understand what I'm saying? So the point is that it is rational, it is not arbitrary. There is a reason why they want to do that. Then I want to raise a note of caution. For us who work, wherever you are, and someone comes to take like 2 bags of 50% dextrose, as a pharmacist, you need to ask, sorry ma'am, sorry sir, is it for one patient? That's the first question. And he says yes, sir. How much glucose do you want to give? Because sometimes they get confused, on how much. It looks so small, 100 mils, and I'm already giving 1 liter. It looks as if what they're adding is small, and they don't know that what they're adding in that 100 mils is more than the 1 liter that they have used. So it's something you need to ask. And on the average, it's difficult for a patient to use more than 1 bag of 50%. Just like it's also difficult for a patient to use more than 1 bag of mannitol. That's another infusion that if somebody wants to take 2, you ask. Because if after 100 mils, 150 mils of mannitol, there's a rebound effect. So those are the kind of things I just wanted to mention that.
Thank you very much.
So someone said that you have to remove the cover and why you to get the baby. So another person said that was what you told that the cover should be
the white cover.
Yes, so please, can you clarify it? Because we are
Well, still in there, blood will not be able to come that far. So all we want to do is remove the needle And before you can remove the needle, you have to remove the white stuff, and then quickly put it back.
My name is Timi Sarah. I'm a pharmacist. I came for the International Clinical Pharmacist Conference. This is our first conference. We are here for the hands-on practical. We've already done the online training, so we are doing the practical now. So we are doing basic life support, first aid. We are also having parental administrative treatments. So we are doing the practical. I've gained a lot. I didn't know how to give an injection or set a drip before, but right now I know all that, and I know how to save life through the first aid and the CPRO. So I've learned a lot. I want to thank the organizers for organizing this program. I want them to continue to impact life and also train others to impact and save life. Thank you very much.
Good evening. My name is pharmacist Ayuba Emmanuel Dago. I actually came for the CPAN conference. I'm a member, a registered participant as well. CPAN has done a very great job. I'm practicing here in Akwa Ibom State, even though I'm from Plateau State. It has been wonderful and a privilege to hold such a conference here in Akwa Ibom State. It has been so impactful. We have learned a lot on the issue of immunization, use of vaccines, and then administrations of medications, some minor medications in our community pharmacies. It has been so impactful. I was discussing with a colleague. Nobody is regretting this. It has been so wonderful. We want to thank the organizers, from the president, Dr. Madu. We want to say thank you for organizing such a wonderful event, and we pray that such will come up every year so that it can really move the pharmacy profession forward. Thank you very much.